Good day, and welcome to this presentation on recreational therapy services in a federal correctional setting. My name is John Rhodes, and I'll be your presenter for this one. Um, just to give you a little bit of background on about myself, I am John Rhodes. I am a recreational therapist at the Federal Bureau of Prisons, and I'll cover that here just a little bit. But I got my bachelor's and my master's from East Carolina University. And after getting my master's, I was like, oh man, I'm going to get a job anywhere I want to go to. I was studying gerontology, thinking that I was going to go work with older adults and be able to work with a very booming population. So graduated from my master's, was like, all right, cool. I'm applying, and I applied down to Florida all the way up to Virginia, out to Kentucky and Tennessee. And my first job I got was in state corrections in a maximum security prison, which was not where I was thinking I was going to go. However, I absolutely loved it. Like, it was a great population to work with. It wasn't where I wanted to end up, mainly because I was the only rec therapist there and I needed to learn more. So I spent 2.5 years working in state corrections. Um, and then I ended up transferring to a state psychiatric hospital called Cherry Hospital. It's located in Goldsboro, North Carolina. And I spent 5 years working there as both a rec therapist and some other collateral duties, and really got a good foundational knowledge of behavioral health and working with that population, which is really important. And one of the things I'm going to talk about later on with working in corrections, because while I was working in both state corrections and at the federal corrections, the knowledge of mental health is such a important part and a big part of treatment for those populations. Um, After about 5 years at Cherry, I decided to keep my eyes open, and a job opened up at the Federal Bureau of Prisons in Butner, and I decided to go that way. So, applied for that. Been here for a little bit over 3 years, and absolutely loving it. The pandemic threw some weird curves in there, but we all had to deal with some stuff that we weren't exactly expecting to deal with, um, and picked up some extra job duties. It was kind of getting well along, but so that's me in a nutshell. I'm John Rhodes. I've been working on this stuff for a little while now, but I'm gonna give you a little bit of overview of what we do in the federal corrections system of like interventions and other stuff. I'm gonna give you just a minute to kind of read through this. You probably have seen it in other spots, but uh, when we're going through and talking about these different uh, treatment spaces and places we're learning about, it's important to like recognize what else is available. A lot of times we don't realize what other facilities offer rec therapy services and where we can go until we stumble upon them. And corrections is a really big one. One of the reasons why I'm always talking more about this is while I was at the state, I actually had 21 vacant positions that I was trying to fill, and I couldn't fill them because I didn't have enough rec therapists willing to come work. And so part of that is also educating where the jobs are. So hopefully you guys got a chance to read through all this. Basically, just watch the entire session and um, enjoy. All right, now for the actual session content. The three things I'm going to kind of look forward to hopefully passing along to you is to be able to identify at least one of the targeted population that I work with in corrections. Um, Hopefully you'll be able to identify two intervention types that are appropriate and like actually evidence-based for corrections, as well as at least one of the things that you're gonna have to do either for training. The other side is like some of the physical stuff. So one of the differences between federal corrections and like state corrections or other job duties is not only do we have to do a lot of training, but we also have to pass physical tests. That being said, bear with me. I'll cover that, but also it's not as big as you think it is. So, anyways, we're jumping into it. All right. So, if you haven't heard of this place, it is in Butner, North Carolina, um, and it is a federal complex. What I mean by complex is it's not just one prison. There's actually 5 prisons up there that range from the medical center, which is where my primary duties are, which is actually the picture that is largest and on the center of the screen. It also, you can see it's closer up in the bottom right of your um, screen. That is one of the big hubs. It is a medical center that is designed for treating inmates who have various medical needs, and I'll talk about the focuses later on. But also, we have 4 other prisons that are there. We have 2 medium camps. One of the FCI is one of the older medium camps, as you can see it at the bottom sort of center of your screen, or at least the entrance. We also have the FCI 2, which is another medium camp that is farther up. We have an actual camp, which is for the lowest points that an inmate can have. And we have a low, which is a lower custody facility. So basically, people will move up and down the custody levels, both based off of what they have done to get into prison, as well as how their behavior is while they're in prison. So if they're acting the way that we would like them to act, they will move their custody level down. However, some of the treatment programs are only offered in certain levels. So for instance, one of the treatment programs will be offered in the medium camp. You have to get to medium points or a medium standing in order to get into that program without us having to advocate for that person to come into the program. But yeah, so Federal Correctional Complex outside Butner, North Carolina. There's also a couple other great rec therapy programs up in Butner with Central Regional Hospital and all those other things. But we're up there with corrections. All right. So just to give you a little bit of an overview of the Federal Bureau of Prisons and like what we're looking at serving. So according to the Federal Bureau of Prisons, right now we have 158,950 total federal inmates. That's a lot. I'm not working with all of them though. It'd be a little bit of a lot of my day if I was going to be doing all that. But with the Federal Correctional Complex, the medical center has really 3 different focuses. We have a mental health focus, which basically states that we're focusing on treating mental illness. And there's 2 different major populations we work with that. And I'll cover that in a lot more detail later on. As well as we have a cancer focus. So the difference is if you are having a mental issue, there's multiple places that they can send you to for different mental crises or for treatment. For cancer, if you have cancer anywhere in the Bureau of Prisons, you're coming to Butner for treatment. So that's the big difference there. There may be other places that we can send for mental health. Cancer, everybody's coming to me. And then our last one is for medical and surgical. So if we are one of the hubs for surgeries and for medical procedures, so if they have a high medical need, they're probably coming to us, especially if they're within this region. There are other medical facilities that can also deal with this. But we're the hub for this region. So, as I was talking about with different programs, we have different programs that folks get into and will stay in. I'm attached to almost all of these with working between the FCI, which is the camp, so it's a Federal Correctional Institute. The medium camp, we have what's called the step down program. The concept is it's a step down from a penitentiary, which is the highest level of security. You step down into that. It's a mental health treatment program designed for 30 to 36 inmates, I think, and all with severe mental illness. And they're actually seeking out treatment. So it's not just your standard, oh, I'm, dealing with mental illness, but I'm not willing to get treatment. Most of these guys sign up for treatment. which is a very unique thing. I have not actually seen that happen very often. We usually have 90 90% 90 to 100% compliance with group participation, and like attendance, which is unheard of if you work in mental health. The other programs that I work at the FCI is in the mental health annex. So this is actually a special housing unit that's designed for mental health inmates, who basically, when they come into this situation, they're under investigation. They're under disciplinary action. They may be having like excessive symptoms where they may become agitated or increasingly violent, where it's time to lock them down before they do something that gets them in trouble. So they get locked down. Typically in SHU, it's 23 hours a day. With these mental health annexes, they're not locked down for 23 hours a day, but they're supposed to be getting treatment and getting out of the cell for more hours than 23 hours. But it depends on the day of the week and what programs are being offered, which comes into play where rec therapy comes in. We can provide some of those hours. At the FMC, otherwise known as the Federal Medical Center, in 1E is our other mental health locked housing unit. This is same situation, just for the medical center. Much larger population. Most times, most days of the week, it's a larger population. These folks are significantly more impaired, and have a lot less to work with. So leisure education becomes very important for them. The other two populations, which I'll dive a little bit farther into, is committed inmates who are basically become wards of the federal government, as in they're no longer able to just go home. They may have served their time, but they're not able to go home. Versus pretrial, which is inmates who have been charged with a crime, but have not been convicted, but they may have gone before the judge and they said, no, this person needs to be restored before they can come before it because they can't help with their own trial. They come to us for restoration and observation and all the things like that. So we have two separate mental health populations go along with that. And then last but not least, we have our medical surgical units that are up on the 4th and 5th floor. Our 4th floor is primarily our cancer treatment program. So if you're going through cancer, you're probably going to be up on the 4th floor, unless your health deteriorates to the point where you need constant supervision. And then you're going to end up on the 5th floor. And 5th floor is for our individuals who are medically compromised and need pretty much constant care or observation or assistance or whatever else. And those folks typically end up on the 5th floor, so that they can have access to nurses and doctors, as well as other treatment programs such as PT, OT, and rec therapy. So a little bit of a review of the programs. Some of the things that we offer our medical inmates, we actually do a very elaborate pain management treatment modality right now. I'll go into it a little bit further in a bit. But we teamed up with rec therapy and art therapy, teamed up with physical therapy, and we've developed a really cool treatment group that is about 10 to 12 week program that kind of covers a bunch of the basic skills for pain management, as well as the other thing we offer for our cancer focus is leisure education. Just basic understanding of what leisure is, what leisure opportunities are available both in the prison and outside of prison, and like what are the benefits of it, and we kind of go from there. Our art therapist also offers various art groups that are up there as well, which is another great add-in for that one. On medical surgical, we offer basic leisure skills, exploration and enhancement. Most of the time it's trying to figure out what do we have that we can offer, as well as like what are they interested in, and we connect them with that. So for instance, I've got a guy who really enjoys classical music, but he doesn't have access to a radio. So I'll bring him up a radio to be able to listen to. And then we'll have a discussion afterwards. And it's kind of interesting because just by providing the music, the nurses have noticed that like the inmate in question will call on them a little bit less, which is a benefit for everyone on that one. But I've also got another one who was completely apathetic towards everything, and then I started bringing up a CD and talking with him about like hard rock music, and I'm getting some brighter affect. I'm actually getting some information out of him where the docs weren't able to do it, so I was able to actually also connect him with our music therapist, and we're going to see how that goes from there. The other thing we offer is comfort care, which is end of life services. So at that point in time, we're trying to connect them with what we can to create a comfortable transition into the next for the end of their life. And it's always a little tough, but it's also like we offer what we can. And then last but not least, we actually offer a structured therapeutic exercise class where they may have already gone through physical therapy and the occupational therapy, and now they need to maintain this. So they do that under one of my coworkers, Billy Preddy, who actually will maintain their exercise routines and keep them moving using adaptive exercise equipment, which I think I'll also cover that later on. So with mental health, as I said, I was going to break this down a little bit farther. We have we got three different populations that I'm currently working with. We have guys who are serving their time, and those are the guys who are mentally ill and in treatment programs over the FCI. They have active sentences. Some of them are long, some of them are short. I've got like guys who have like 200 months, so they're never getting out. And then I've got other guys who they've got like 14 months, so they're just about to the door. And I have discharged folks before. So we're actively treating folks who are coming back into the community and those who will be there for a long time. That's a very different population than what I'm working with the committed individuals. So the committed individuals have completed their sentence, and with completing their sentence, they were then put before a judge and said, no, you're not safe to go back to the community. You're a danger to yourself or others. So cool, you're stuck. We're going to review you every year. And if you make the progress we need to see, we'll consider you for a structured release or a non-structured release, and then we'll go from there. That also includes individuals who are convicted by not guilty by reason of insanity. Those individuals can come to us or can come to other like state psych hospitals or other places, depending on like where the crime was committed, where it had lots of different things. But we have individuals who are that way. The saddest thing is a lot of folks who end up taking that path think that that's a quicker way to get out. And usually it's actually the opposite. A lot of folks, if they'd just taken a plea deal or just done what they needed to do, would have gotten out significantly quicker than what ended up happening to them. And then the most volatile, interesting inmates we have are pretrial inmates, otherwise known as forensic inmates, which if you guys work in state psych hospitals or even like some private ones, if they are there by the wards of the state, you're dealing with the same population. You just maybe don't have as big of a concentration as I do, because I think we have somewhere like 100, 120 of them with us. And these are individuals who are needing evaluation and rehabilitation for returning on to trial, which we offer a variety of classes, mostly through psychology. However, I was also helping out with some of that with a Slater method and a cognitive remediation portion. But that is a very interesting population. It's also one of our more volatile because they haven't been down for long. They haven't been in prison for very long. So it's always an interesting population. All right. As I was just talking about with forensics, this is actually dealing with folks who are dealing with legal problems. one of the things we're doing with them is we're preparing them for court. What I mean by that is they need to be able to identify who's in the room, as in what is the job for every person that's in the room, as well as what are the pleas, as in guilty, not guilty, not guilty by reason of insanity. Also to recognize what a plea deal is, and as well as to be able to rationally think through what is your better option for a plea deal versus a taking this to trial. Is it going to be a jury trial, or is it going to be a non-jury trial? So done by the judge, like basically judged by the judge. And we got to go through all that. Well, a lot of times we have to add to that like something else. We got to put some form of treatment with that. So we'll add in like the education of what's going on with it. But individuals who are severely impaired may need a little bit more treatment and may need a little bit of setup. So we'll connect them with, or we were connecting them with a cognitive remediation portion. I think that is put on hold for just a little while, but we'll get there along the way. All right. Think about this for just a second. Think about what you wear to work. So I'm going to cover a little bit of the logistics of what I have to wear to go in and everything else. So think about what you wear. Do you wear scrubs? Do you wear business casual? Can you get away with a t-shirt and jeans? Or is it like athletic wear? All of that's awesome. Because unfortunately, I got to wear a stab resistant vest, resistant, not proof. I have to wear a duty belt. That on the duty belt, it is like the worst Batman belt ever because it carries keys, a radio, a thing of pepper spray, and handcuffs. Now, the interesting reason why I actually carry handcuffs as a therapist is for their comfort and for the ease of programming. So what I mean by that is we've had a bad day at the prison where we had to go and empty out an entire unit. So 45 guys, we had to cuff them all up and move them out. Well, we didn't have enough cuffs for all of them. So we used what's called flexi cuffs, which you may have seen those on TV. They're the little plastic zip tie things. Well, the problem is zip ties don't lock. So as you move, they tighten. And eventually they just tighten so it's basically cutting off blood flow. And at that point in time, we have to cut them off and put new ones on. And that takes time. When you got 45 guys out there, it's not a thing. But with handcuffs, you can lock them in place so they don't continuously tighten. So that's one of the reasons why I carry it. And for any of the groups that are in the annex, we have to cuff them up to move them to the treatment area. It helps if I've got the ability to do that. The other thing is if you think about keys, you're used to the little itty bitty keys that are that way. The Folger Adams keys that you see up here, I don't actually have to do the Blues Brothers picture on it. That's not a part of it. But I have 4 of those Folger Adams keys that are about the size of your hand. And I have to carry 4 of those along with about a dozen other like door keys. In order just to be able to get around on a regular basis. So it's a good bit of weight that's on there. And so it's always interesting. You never know what you're going to get. But it's quite a little bit to go along. I usually wear a business casual setup beyond that, with the exception of instead of khakis, I have to wear tactical pants. And ironically, a lot of people are like, oh yeah, you wear tactical pants because you're in corrections and that way you can hold all your gear and whatnot. And I'm like, no, I'm a rec therapist. I hold all my games in my pockets. And it's funny because they laugh because it's like I'm literally pulling decks of cards out of my pockets. So it works. Some of the trainings we have to go through is a little bit different than what I was expecting. So for instance, I have to do SCG, or Strategic Threat Group Identification classes, where I have to be able to go through and identify various gang groups, which are very interesting because they weren't even the same ones that I was dealing with at state corrections. But gang affiliations, as well as just various threat groups. For instance, the Sovereign Citizens one is a very interesting population that is not an organized gang, but it is a group that has decided that they are sovereign citizens. Therefore, they are not subject to any of the laws of the land. And the problem with that is that they will literally do things that they're like, it doesn't affect me, so therefore, whatever. Well, it runs into a lot of this also triggers psychosis. So some of this goes in between it. We all have to have CPR. That's just a normal thing for any rec therapist. But we also have to be trained for disturbance control training, where we have to be able to suit up in combat armor and be able to retake an institution if it gets taken down. Not what I was expecting. I also had to go through firearms and pepper spray training. Did not realize as a rec therapist, I didn't have any of my professors explain to me that I'm going to have to be certified in a 9mm handgun, an M16, and a 12 gauge shotgun. Nobody explained that to me. I mean, it's fine. I pass everything, but that's one of the things I do as a rec therapist. It's weird. Also do self-defense. We also do mental health trainings. We actually just had a excellent training on interactions with individuals who are transgender, because that is a big population we work with in the correctional setting, as well as different physical medicine training. So actually, we go up and do a rehab training conference every 2 years in Denver, Colorado, and we get to go through some of the various trainings that go along with that. We do have additional duties, since the weirder things with being at a federal correctional system, everyone comes in as officers first, which means you have to be able to do what an officer does at any given time. So I do get augmented. So you basically become an officer for the day. That only happens about once to 3 to 4 weeks. And we're just filling in when they're short. It is really good for them to be able to see that you're on the same level as them. Like, the officers don't treat you as any different because they recognize you're one of them too. But it does, throw a kink in your day. We also are helping with the COVID screenings. As I said before, with the pandemic, everybody picked up additional duties. My department was helping with COVID screenings. I specifically was helping at the Federal Correctional Institute, the medium camp. I would be there every Monday while we were doing this for about 2 years. And I was there for 1 to 3 hours, basically screening for COVID symptoms. And yes, I would send you home if you came in with anything. We also every once in a while have to fill in other departments. I actually had to fill in commissary earlier this week, where commissary is the store where the inmates can shop. And once every 3 months, they have to shut everything down, count everything, and make sure that they're not losing major amounts of inventory, or if things are coming in wrong or whatever, because they have to do so many fact checks, because we're dealing with inmates. Some of them aren't quite as honest as other folks are. And so we have to go back and kind of do that. And I've already covered why I carry cuffs. So moving along, some of the physical requirements, as I said before, it's not quite as bad as a lot of people think it is. Basically, our physical requirements is you got to be able to do a 1/4 mile sprint and cuff a compliant person. And you got to be able to do that in 2 minutes and 35 seconds. It's really not as scary as it sounds. If you can easily train up for that. It's not that terrible. We do those sprints on somewhat of a regular basis, just with various things going along. We have to do a 75-pound dummy drag for 7 minutes, and we have to cover X amount of space. So I think it was 3.5 basketball courts. So you got to be able to drag it 3.5 basketball courts down. And then we have to be able to do 6 flights of stairs, and I think it's 1 minute and 6 seconds, something like that. It's, completely doable, because it's up a flight of stairs, down a flight of stairs, up a flight of stairs, down a flight of stairs, and then one last set. So you do 6 flights of stairs. And then the last but not least is an obstacle course, which basically it's a prison obstacle course, which is weirder than any other ones because you got to be able to open a Folger Adams door, jump over a desk, under a desk, zigzag, open another Folger Adams door, collect something, shut the door, lock the door, back through, and then shut and lock the door the last time. So a little bit different, but I think you have 56 seconds for that. Like all of these things I passed without any problem. So it's not that huge of a physical requirement thing. But it is one of the things they do want to make sure that you're able to do this just because we do have a very physical environment. So they do want to make sure you're going to be able to pass the bare minimum for these tests. All right, so where rec therapy fits in the interdisciplinary team at the Federal Bureau of Prisons complex. So I actually fall under the rehab department along with physical therapy, occupational therapy, wound care nurses, though I think we're down to one wound care nurse. We also have a contract art therapist. There's 2 rec therapists there right now, and we were going to bring in another one, but I couldn't find one. So I found a music therapist to fill in. So we just brought a new music therapist on board. And if you're ever interested in working in corrections, like reach out to me because I hear a lot of the job openings. So just reach out. We also fit into the treatment teams, both in the medical side and the mental health side. I do more with the mental health side than I do medical for the treatment teams. But right now, we fit in with psychology being one of the primary folks for mental health teams. With the psychiatrist, there will be nurses there, pharmacy, rehab, social work. And one of the things I left off there is also the correctional officers. So the correctional officers are actually a really big part of the treatment team as well, because they see the folks day in and day out. So it's a really big thing there. So now we get to do a little bit more of the fun stuff. So talk about intervention. So one of my coworkers, Billy Preddy, runs a vocational workshop, which is designed on creating opportunities for work for both the mental illness guys as well as severely physically impacted 5th floor individuals. So what I mean by that is we've got a hygiene program. So that basically is making sure they have clean clothes and have like basic soaps and stuff like that for individuals who are severely impaired. And we have inmates who actually help take care of that for them. We also, so they fold and get laundry laundered and iron the clothes. We also have a print shop where we put together a lot of the paper documents for the complex. All of that is collated and put together by our mental health inmates and our physical rehab inmates. We also have different sets that teach them on janitorial jobs, basically teaching them how to do the basic janitor job. And then we actually end up moving them up. So we'll start them in the shop and then they'll get to be promoted into either food service or into trash orderlies or something else where they can end up picking up skills that they can take out with them into other jobs. And we also bring in, that's both for our mental health and for our physically disabled. So we'll have individuals with paraplegia, quadriplegia, stroke, all coming down to work on the bilateral stimulation aspect of the print shop, as well as task orientation and attention span, and just also getting them out of the environment that they're constantly in and into something different. So we do all that through the vocational rehab stuff. I actually opened up a therapeutic garden last year, and we actually have that attached to the one of the committed guys' units. So we're able to get them out pretty much anytime they're out. We can go out there. Right now, the tulips and the not dandelions, daffodils are coming up, and our rose bushes are like, this is weird weather. We're gonna go ahead and start putting out leaves. I'm like, no. Okay, I can't stop rose bushes, but the garden's actually doing fairly well. Last year we had a really big outcrop of marigolds and tomatoes. So we're hoping we'll see something similar this upcoming time. I've also run a drum circle at both the medical center and at the medium camp. The medium camp was way more successful. We actually have run that one for, I think we ran it for 24 or 36 weeks. And that's just a fun experience to hear all the guys be able to play and make some music. Luckily, I passed that along to one of our music therapists that just came on board. Um, I also did a music appreciation class where basically a lot of the guys listen to the same music over and over again because they do actually have MP3 players and they have to buy their music. So the MP3 player is $100, and then they have to buy each song for like $1.50. And most of them are not making significant amounts of money, but also a lot of them would listen to the same music. So if they didn't have it on their MP3 player, they wouldn't be able to listen to it. So we had to kind of explore some different types of music. And I couldn't exactly get in an iPod and iPad or anything like that. I literally had to order CDs and have them listen to CDs as we went along. Because this is one of the hard things is we're very technologically limited. So exercise is also one of our big interventions, both with mental health and with med-surg. So with mental health, a lot of times we get them outside, we'll get them moving, doing with either a walking club or with a structured exercise program. And it's always interesting because there's always some folks that are a combination of there's some mental illness going on, but there's also some physical stuff going along as well. So we've got to be mindful of that. But also our big one is for medical surgical, we actually have a therapeutic gym. So we can do anything from getting folks into a standing frame. So you can actually see the standing frame in the middle of your screen. That is not one of our participants. That is a stock photo I found online. Or to the hand cycle, or we have several different other pieces of adaptive equipment where individuals can come in and do their exercise in a therapeutic setting and maintain their fitness, even though they may have been discharged from PT or OT. They still need to be able to use these adaptive equipment for those purposes. Some of the other interventions that I've offered is stress management and relaxation skills. These are basic skills where they get to learn a little bit about what stress is, how it affects their body, and what are some of the techniques that they can use to relax. Cognitive remediation is one that I've touched on a couple of different times. So cognitive remediation is actually the concept of if a person experiences psychosis, the theory is that they also, when they experience psychosis, they've found that there are cognitive deficits that arise, specifically in skills such as attention span, problem solving, information recall, and there's another one. It's fine. I'll get to, you'd have to sit on my other one with it's got the notes with it. But all these concepts are really cool. And cognitive remediation has come out, which is a great thing, but most of the treatments are online. As in they're done through phone apps or tablet apps or online resources, which is great for if you're in the community. But in prison, we don't have access to those things. We just don't have access to the volume of games and interventions to do that. So I've adapted to a rec therapy modality where I have various interventions that line up with those same exact targeted skills, and we work on providing the therapy for that side and see where the deficit is for specific individuals, so that we can find out what we're going to connect with. So that is a very big one that we would line up with what's called the Slater method. The Slater method is one that's designed around individuals with lower cognitive functioning capacity. And instead of it being like we're going to cover all the course material once, they cover it 3 separate times. They'll cover the same material so that an individual has more time to listen and like absorb. And then we would add this in both to see where the cognitive deficits were, as well as what can we strengthen to get them back to restoration. Because most of the time you're better off being able to be restored, go back and face your charges, whether you're guilty or not. I don't really care. You just need to be able to go and function before the courts, because going through that process benefits you more than not being able to complete that process. Um, we also offer cinema therapy, which is actually based out of emotional intelligence. Um, the concept with that is that we can use TV shows and movies to talk about and experience like the emotional intelligence side of things. Because one of the things that is they've noticed with individuals with psychosis is they do not recognize emotions as well. That's not just emotions within themselves; it's also emotions in other people. So it's a learning lesson of talking about emotions both on their own side of emotions, but also on recognizing emotions in others. Because that is it's one of the things, it's a skill a lot of times with severe mental illness and severe psychosis specifically, that skill oftentimes gets lost. And we kind of go from there. Therapeutic media is basically a therapeutic art class that I've done in the past. I don't do it as much right now because we've got an amazing art therapist who I'll talk a little bit more about some of the interventions he's done. But it is a good little thing to kind of throw in every once in a while with various classes. Leader skills and leader education, I do both for the cancer focus, the mental health locked housing units, the mental health units, and with med surg. So pretty much everybody gets that. And it's basically exploring what leisure opportunities do they have both at the prison as well as what would they be able to get access to if they were heading back out the door, as well as like exploring what would be affordable versus what's not, because a lot of these folks, even if they're going to get back out the door, will have significantly limited job opportunities because of the fact that they'll be an ex-con. Um, so exploring those leisure interests that are affordable and something that people can do. Um, and also getting mental health guys to recognize what else is available on the compound is important. For instance, one of the things I did with the medium camp was get them connected with the chaplain, because a lot of times the mental health guys will not reach out for the chaplain services and what they have available in the chapel, because mental health doesn't always feel comfortable going to these religious settings. And if you worked with mental health, you know how much spirituality can be very important towards their treatment and long-term health. And if they're not getting that portion, it can significantly impact them. So connecting them with that was a huge part of their leisure education. Team building is also another one that I do, specifically with the step down program, because it is the same 30 to 36 guys that will be there for 6 months, creating the community, creating the team building, helping them to recognize this is not the same setting as most of the prisons that they're used to. This is a therapeutic environment, and they're expected to treat each other with more respect and more dignity than with other things. And so creating those team building activities and that ability to work together is really, really important. And any of that can range from, going through the minefield, which I adapt a little bit to it, to working together on team-based trivia games and other basic low ropes course activities. I will say it this way. The minefield one's an interesting one because like there's no way I can blindfold inmates. I can just see it on the headlines now. Therapist blindfolds inmates. Lawsuit ensues. But there's ways to adapt that kind of stuff. So instead of having them go forwards, I have them go backwards. And so like that way they have a less chance of seeing the mines ahead of them. But at the same time, like some of that's just you got to adapt as kind of go along. And then therapeutic one-to-ones and locked housing. So for instance, I do both the leisure skills exploration, see what they like, but I also provide them with a lot of opportunities for leisure that's in the locked cell. For instance, right now we're doing a book study with guys who are in the locked up unit, where we're studying the philosophy of Star Wars. Just a very big nerdy thing. I offered the book, but it was not, there were like 3 or 4 offerings. This is what they chose. But it's been really interesting because some of the guys are very intelligent, but a lot of the treatment techniques are aimed at individuals who are lower functioning. So I provided something that was more towards their focusing with this book club where we're reading basically a chapter a week, and then we're getting to discuss it afterwards, and getting a chance to kind of explore some different treatment modalities in other ways. So that's sort of some of the things that we do with that one. All right. So as I said, our pain management is kind of one of our cooler techniques that we're doing right now. Right now we have it on Tuesdays. It's a massive collaborative project. This is I think fourth or fifth generation that we're doing now, 10 to 12 weeks, usually around 12 weeks. But one of the things they found is that cancer pain management among prisoners is like a really important thing to be tackling back in 2005. And so it's one of those things of like, we've been dealing with this for a while, and we've been working on adding this in, and every generation does a little bit differently. I think ours is really a solid program. It's a collaborative project with physical therapy running the first hour with guests. So they will cover the majority of the physical side of things. So they may cover, sorry, I'm about to sneeze. Hopefully it can go away. Apologies. Nope. Sorry. They were on the majority of like the physical based stuff. So exercise, like explaining how exercise and pain are associated together. They do a great job of kind of doing that, but they also bring in other guests. The OTs talk about the spoon theory. The dietitians talk about how different foods deal with inflammation and how that affects pain. Pharmacy talks about how meds can interact with both your pain and which ones are appropriate for different types of pain, as well as what medicines to avoid. And then psychology is on board for teaching cognitive behavioral therapy for pain as needed. And then for the second hour, so it's a 12:30 to 2:30 time slot. So from the 12:30 to 1:30, that is the physical therapy and their guests. From 1:30 to 2:30, we are dealing with art therapy and rec therapy. So one of the things that our therapist, which is this is his pain monster, we do a combination of art and rec therapy type activities or interventions to cover these topics. So for instance, this is his pain monster. We have the guys create their own pain monster. So it's basically like a physical manifestation of their pain. So our art therapist has actually been blown up because he was in the military and was in a caravan that hid an IED. So there are times where he has a lot of pain going along in different areas. As you can see, he has a lot of pain in his hands. So those are like knives coming out of the hands that he's kind of representing here. So we kind of go through and provide the guys a physical manifestation of the pain, because then if you can identify the pain that way, sometimes it's easier to talk about and sometimes it's easier to kind of go from there. I provide interventions such as like guided imagery and progressive muscle relaxation, and explaining how like the stress response interacts with pain, and how the stress response is one of the things that we still need to deal with as we kind of go along. So this is a really great intervention type that we've been doing. Very collaborative, very interdisciplinary, as well as the guys kind of working on it and getting a lot out of it if they put their minds to it. We've had one or two classes that just was not engaged, and you're going to get out what you put in. But as therapists, we're not there to make them get anything out. We're just there to provide them with the tools and see what they take away. All right, covering the API process, because this is one of the things all of us need to know. We get several different referrals. There's two different types for me, though. So there are referrals that I get basically if they get assigned to a unit, they're an automatic referral. So if they're referred, I'm supposed to go deal with them within 14 days or something like that. And those assigned units includes the fifth floor. Two of the sides of the fifth floor are automatic catches, and step down for the FCI. Automatic ones. Now, I can also get referrals from the physician's assistants or the doctors or from psychology. And those individuals, I will then go and add them to the caseload as needed, depending on what the referral is about. A lot of times we get referrals for the physical exercise that we do. So the adaptive exercise that's done. And then the other one I'll get a lot of referrals for individuals in the special housing units for the mental health locked up units. Basically, anybody who's is going to be there for more than a couple months, they'll refer to me so that we can explore their leisure opportunities if they're interested in that, and if they're not, we'll readdress in 6 months. So we do have the assessment. It is redone every 12 months, unless they're in active treatment. The good and bad thing is it's a little bit different than even when I was at the State Psych Hospital. These guys aren't going anywhere, so like our time requirements aren't quite as stringent as some of the other ones were with other settings. We'll do an assessment, figure out what they'd be appropriate for. We'll then apply them to RT services, and then we will document through daily or weekly flow sheets. Basically, that's a daily entry of what they've done for that week, and then we'll complete notes, and then we'll also provide reports to treatment teams and to the actual PAs and doctors. A lot of times it's easier just to kind of go walk through it. We do have an electronic medical record, so I'm able to put in my documentation from any computer that is on the complex, which is really nice. So I can kind of just drop those things in, and we'll get those plugged in, and as I said, daily, and then we'll get our notes in done typically between 30 and 90 days. Most of them are 90-day notes. Once again, these folks aren't going anywhere. The individuals who are our studies, those are 30-day notes, just because they're not necessarily going to be here as long. But at that point in time, once we do the notes, we then reevaluate them for, are they still appropriate for rec therapy services? And the same number, or do they need more? It's just depends on where we're at and with what's going on. And then we'll review and see what we need to do from there. All right. Just covered a couple common questions that I usually get, asking what the work schedule is. I work Monday through Friday, 7:30 to 4. So I don't work weekends. I have been asked to do some late nights, so I'm going to do probably one late night a month here coming up. That being said, I can also pick up overtime. One of the nice things is about this particular job is I can pick up as much overtime as I would like or not to. So I don't have to pick up any overtime, but I can pick up overtime. You are picking up overtime as a correctional officer, not as a rec therapist, though. So there is that. How many patients do I have on my caseload? That is always been a good question. And honestly, I have 30 patients over at the FCI. And then I have something like 210 over at the Federal Medical Center that I work with on a regular basis. Which is a little bit ridiculous. But at the same time, like we've got 750 inmates at the medical center. So, I'm working with a good portion of them. Do I take interns and practicum students? As of right now, I do not. I have put in paperwork trying to get that approved, but unfortunately, combination of due to COVID and just the how secure this facility is, I can't get students in right now. And then the last question I've got is that a lot of folks ask is like, how would you get prepared for working in corrections? A lot of people don't like my answer because I started by doing private security for like 10 years before that was my college gig before coming on board. However, one of the things I can suggest is working in behavioral health. Like, go work at a state psych hospital, go work in behavioral health, because a lot of those skills are going to get transposed over to that. So sorry, those are a lot of common questions I usually get. since you guys are on a virtual session, I can't necessarily take your questions. That being said, you're welcome to send me an email. I'm going to let this be up here just for a minute and go ahead and say, thank y'all for joining me today. Hope you guys enjoyed learning a little bit about what we do in the Federal Bureau of Prisons. And we'll move on to the next one. And if you have any questions, if you want a copy of the PowerPoint, if you want to reach out to me, have any questions about corrections, or anything that goes along with that, please send me an email. And if you want to know any more about cognitive remediation or anything that goes along with that, please send me an email. And beyond that, thank you for your time. I hope you guys have a wonderful rest of the conference, and hope you guys get to learn a little something. I'm going to flip this over to my resources, and hope you guys have a wonderful rest of your day.